Good morning, everyone. It's just 8 o'clock now on Thursday, April 18th. Thanks for joining our cardio echo hypertension session. This is week 10 of 12. And I will ask everyone to chat your name in the chat box to record your attendance, please. If you're on the phone, I don't see anyone here that we need to call out. So that's great. If you get disconnected, there's a phone number there to call, and the meeting ID, you can enter that in to join via audio. We'll keep you muted unless you have a question. You can unmute yourself, or you can also put it in the chat function. And we'll go around the room here at the Echo Hub to introduce ourselves. I'm Shannon Switkowski. I'm the clinic coordinator.
I'm Rick Carnacci, the web content producer.
Jesse Lewis, project manager here at CASE.
Jackson Wright, a part of Cardio.
Gautam Rao, I'm the director of the ECHO program within Cardio.
Sheru Kansal, nephrology at University Hospitals.
And Dr. Rao.
I went.
Okay.
Okay, but I'm happy to, you're turning things over to me. Thank you, everyone. Thanks for joining us. We are past the halfway mark, well past the halfway mark in our ECHO series initially. So I'm very pleased to welcome Dr. Kansal here. He is with our nephrology division at University Hospitals. He's going to be speaking this morning about secondary hypertension, which of course is a significant and often overlooked issue within hypertension overall. So I'm going to turn things over to you.
Great, thanks very much. Good morning, everybody, and thanks for joining us. I have structured the talk to really provide you with approaches that are going to help manage your patients with high blood pressure, particularly when there's a concern for secondary causes, and really give you pragmatic diagnostics and suggestions when you're trying to treat these patients. And this is really, when I'm seeing patients in clinic, this is really how I think about, secondary high blood pressure. So we're not going to really be talking about a ton of data, but really more, day-to-day management of patients with high blood pressure. Next slide. So in terms of objectives, we'll define secondary high blood pressure. We'll list some common causes of high blood pressure, and then the goal would be for you guys to be able to describe some diagnostic and evaluation of patients with concerns for renal disease, hyperaldosteronism, and other causes for hypertension. So just to review epidemiology briefly, essential hypertension, as I'm sure you all know, is the majority of patients with high blood pressure. 90 to 95% of patients with hypertension have essential hypertension, and that's really based on genetics, diet, age, activity level, and things of that nature. Secondary high blood pressure accounts for 5 to 10% of everybody with high blood pressure. The most common reason, under the umbrella of secondary high blood pressure tends to be chronic kidney disease. To be very honest, I don't really kind of view chronic kidney disease as a secondary cause of high blood pressure, just because as a nephrologist, this is what I do day in and day out. And I kind of view secondary high blood pressure as kind of like a puzzle that you got to kind of solve, but chronic kidney disease is generally fairly obvious. But we'll kind of review optimal management of high blood pressure and chronic kidney disease and kind of the pathogenesis of CKD related to hypertension. And then we'll talk about spend a little bit of time on renovascular disease, particularly the diagnostic evaluation and trying to determine which patients are eligible for treatment to help narrow kind of the diagnostic testing. We'll briefly go over meds, obstructive sleep apnea, and then I also want to spend some time on primary hyperaldosteronism. So in terms of CKD and hypertension, as I'm sure you all have experienced, hypertension is very common in CKD patients. And also, as the CKD progresses, the incidence of or prevalence of hypertension increases. And the pathogenesis is really multifactorial. There is sodium retention. Whenever there is CKD, you're going to have sodium retention. And even if there isn't any edema, the extracellular volume is likely expanded. And so for most patients with chronic kidney disease, you're going to at least need some sort of diuretic to control the blood pressure. There's also increased renin and angiotensin activity and increased activity of the sympathetic nervous system. As I'd mentioned, diuretics are a mainstay of therapy for hypertension in chronic kidney disease. Chlorthalidone is generally my main primary diuretic of choice rather than hydrochlorothiazide. The half-life of hydrochlorothiazides is a lot shorter than that of chlorthalidone. So chlorthalidone tends to have a little bit more efficacy in terms of controlling high blood pressure. When I'm thinking about dose equivalencies, I think of 12.5 HCTZ, 25 HCTZ, and 12.5 of chlorthalidone, and then 25 of chlorthalidone is my max dose. Tends to be the highest, most potent type of thiazide diuretic. Generally, we don't go much higher otherwise in terms of thiazides because the blood pressure response kind of dwindles after those doses, and then you just get more side effects. When the GFR is less than 30, typical teaching is to use a loop diuretic such as Lasix or Demodex or Bumex due to the decreased efficacy of chlorthalidone. Go ahead, next slide. So in terms of specific management of high blood pressure and chronic kidney disease, the proteinuria status is important in terms of determining optimal therapy. For patients with proteinuric kidney disease, as I'm sure you all know, ACE inhibitors and ARBs are the treatment of choice. It blocks the renin-angiotensin system, so it attacks one of the primary pathogenesis of hypertension and chronic kidney disease, and it helps reduce proteinuria and thereby slowing progression of CKD. One comment I did want to make is regarding the combination of ACE inhibitors with ARBs, or also ARBs and direct renin inhibitors. Both of those combinations, particularly in diabetics, have been shown to reduce proteinuria more so than monotherapy, but are not recommended because they did, when they looked at the primary outcome of renal outcomes, there wasn't any benefit despite the improvement in proteinuria, and there was also increased risks of AKI, hospitalization, and hyperkalemia. And additionally, it doesn't provide a ton of additive benefit on blood pressure. That being said, there are certain situations where ACE and ARB combinations can be helpful, particularly in IgA nephropathy and things like that. But in terms of, for your guys' perspective, I would probably lean on your local nephrologist to kind of make a determination of whether combination therapy is going to be advantageous to the patient. If the blood pressure is, in proteinuric CKD, if blood pressure is not controlled, second-line therapy is generally diuretics. That enhances the antihypertensive and antiproteinuric effect of ACE and ARBs by activating the renin and angiotensin system further. And so you augment kind of the effect of ACE inhibitors with diuretics. And if your blood pressure still is in control, the next line of therapy, overall first line is calcium channel blockers. So you just kind of go through a stepwise approach in proteinuric CKD. For non-proteinuric CKD, there really isn't any specific data that would suggest that any specific class of drug is any more beneficial than any other. But given the pathogenesis, diuretics and ACE inhibitors and ARBs generally are first line. But in terms of trying to optimize patients' prognosis, as long as you get the blood pressure under target, there's no benefit over one drug versus the other. So for renal vascular hypertension, outside of chronic kidney disease, that tends to be the second most common cause of secondary hypertension, although there's some controversy regarding that, and we'll talk about that in a minute. The etiology is generally for atherosclerotic disease, ASD, which is generally 2/3 of the cases, and fibromuscular dysplasia represents the rest of it. Pathogenesis is very similar to chronic kidney disease in terms of sodium retention and activation of the renin-angiotensin system. A big question in renal vascular diseases is whom to revascularize. for fibromuscular dysplasia, revascularization improves blood pressure in the majority of patients. However, that is not true in revascularization in atherosclerotic disease. And there's one potential explanation for that is that patients with large vessel atherosclerotic disease likely have small vessel atherosclerotic disease, and so revascularizing the large vessel ultimately will not have a huge effect in terms of renal perfusion. And there are a couple of large RCTs that have been done and that really didn't find any benefit compared to medical therapy in terms of renal outcomes or cardiovascular outcomes. That being said, there have been a lot of observational studies that have shown benefit to revascularization, but those have been observational studies, and the thought is that there's a significant amount of selection bias in these studies. When you're looking at patients with renal artery stenosis without any other specific criteria, you're going to get a lot of people who are not going to respond to therapy, whereas when you are looking at people with very resistant high blood pressure or other specific criteria that is generally done in the observational studies, you're going to see a different result. And so expert guidelines in terms of criteria for revascularization are progressive ischemic chronic kidney disease, and that's sometimes hard to figure out. You really don't know. Sometimes it's difficult to determine if the progressive CKD is really just from high blood pressure or from progressive ischemia. If the kidney is shrinking in size, that's generally my indication that there's progressive ischemic issues. However, it's difficult to know if you've reached the past the point of benefit at that point. But that's a challenging one to figure out. Failure of optimal medical therapy or intolerance. A short duration of hypertension. So if somebody's only had high blood pressure for a short period of time, they probably don't have a large amount of small vessel disease and presumably will respond to revascularization. And then recurrent flash pulmonary edema or refractory heart failure are other indications for revascularization when somebody does have atherosclerotic renal artery stenosis. So in terms of diagnosis, patient selection is critical. And so, be very frank with you guys, I rarely check a renal duplex on a 60-year-old or older patient until I'm getting to the point where I'm running out of options in terms of controlling blood pressure, because I will rarely send that patient for revascularization. And so I don't generally even approach testing for renal vascular disease in those patients.
That's just for screening. Sure, you don't know at that point.
You don't know. Yeah. I don't even, so I try and manage the blood pressure regardless of even if there's, somebody's got significant atherosclerotic disease, abdominal bruit, et cetera, sometimes we do it just to know, but focusing on the blood pressure or thinking about intervening is not until I really am not able to get that blood pressure down. And also optimizing medications are important. And so I think there is this, there's this feeling in renal artery stenosis that you can't use ACEs and ARBs. And while it is true that they may increase the creatinine, they are generally going to be the most effective drugs in controlling the blood pressure when there's renal artery stenosis. And similar to what I tell my patients, the blood pressure is more important than the creatinine to a degree. And so generally, when I'm managing a patient, I focus on the blood pressure, and then we see how the creatinine, where it settles down to after we've gotten the blood pressure on target. And as long as it's not a huge decline in renal function, it's okay for the creatinine to go up a little bit because the blood pressure is more important. Then talking a little bit about specific testing, duplex is generally the screening test. although there is a lot of interoperator variability in not only in the actual ultrasound pictures that are obtained, but also interpretation. CTA and MRA tend to have much better sensitivity and specificity. The CTA requires dye load, so a good chunk of these patients are going to have chronic kidney disease, so that's something to be aware of. MRA may or may not require gadolinium. With time of flight images and things of that nature, in 2019, I haven't really had to give patients gadolinium when we end up going with an MRA rather than a CTA. And generally, there's just conversation with your radiologist, and they can help you figure that out. Captopril-renogram is not something that is generally recommended anymore. It has good specificity, but poor sensitivities. You'll miss a lot of patients that will respond to revascularization if you rely on that. And then the plasma renin, as I'd mentioned, the pathogenesis of hypertension is at least in part due to activated renin and angiotensin system. So checking plasma renin has been a thought as a potential diagnostic tool, but it doesn't have very good sensitivity or specificity. So we'll kind of leave renal vascular disease at that. With that, if you have any other questions.
Sure, I think we want to address Dr. Boland's question.
Sure.
It says, how much of a decrease in GFR would you allow?
So generally, it's similar to ACE and ARBs with diabetic proteinuric kidney disease. The typical guideline is a 20% change in creatinine. A lot of, I wouldn't use that as a hard rule. A lot of it is relative. If you've got somebody with a normal creatinine and it 0.9 and it goes to 1.5, I think that's probably okay. However, if you've got somebody with a creatinine at 2.5 and it goes to 3.5, that's probably a little much. So it's relative, and from my standpoint, it also the CKD prognosis is also something that needs to be kind of part of the discussion in this as well. For somebody with non-proteinuric chronic kidney disease that is presumably related to high blood pressure, as long as you get the blood pressure on target, one wouldn't expect them to have progressive CKD. And so that's why generally, my general approach is we got to get the blood pressure down and then worry about the creatinine. Because for most of these people, as long as you get the blood pressure down, even if they have a good amount of kidney disease, they're not going to progress unless obviously there's a new issue, they have an MI or they get septic or something of that nature. But the natural course of the non-proteinuric kidney disease is really, as long as the blood pressure is controlled, is to really not progress. Sorry, go back one slide. So quickly, just spend one slide on obstructive sleep apnea. A patient, as I'm sure you all know, patients with OSA are more likely to have hypertension than non-OSA, and it's kind of vice versa as well in terms of patients with resistant hypertension often have obstructive sleep apnea. The thing that I found a little bit surprising is that the treatment of OSA doesn't affect in any major improvement in blood pressure, although you get some minor, significant in terms of statistical significant. Whether it's clinically significant, I'm not sure, but there you will get some improvement in the blood pressure with treatment of the OSA. The severity of the OSA does also correlate with the improvement in the blood pressure with CPAP therapy. And then one other comment is just most trials that have looked at CPAP, but other devices in terms of observational studies do seem to have helped. Next slide. So drugs, just a couple of specific things that I wanted to talk about. I know one of the cases talks about a young female. Estrogens are a major cause of drug-induced high blood pressure. Progesterone does not increase blood pressure, and so progesterone-only OCPs and things like that are recommended for females that need some sort of contraception rather than combination pills or estrogen alone. Non-steroidals as I'm sure you all know, due to afferent vasoconstriction will lead to sodium retention, activation of the renin-angiotensin system, and high blood pressure. Phenylpropenes, the main one to be aware of is Sudafed. Typically in winter season when URIs are very common, people will start taking some Sudafed, and that'll definitely make your blood pressure go up. There's a question about Adderall. Yep, Adderall will also, and that's phenylphentermine, will make your blood pressure go up. Appetite stimulants will make your blood pressure, all of those can increase your blood pressure. Those are the biggest culprits that I tend to see.
Sibutramine off the market now.
Okay.
Secure message.
In terms of this question regarding Celebrex not associated, but on their NSAIDs all do, I haven't seen that. It's very, I think that's not an unreasonable thought. It's the non-steroid aren't a huge culprit, and otherwise, it's generally not that challenge, to get the blood pressure down. When somebody's got very resistant high blood pressure and we're really on 4 or 5 drugs, and that's when I start worrying about the NSAIDs and things like that. So from a practical standpoint, I'm not sure if that is something that really changes how I approach things in terms of Celebrex versus the other NSAIDs. Next slide, go ahead. So primary hyperaldo is something I want to spend a little bit time on. In terms of the initial slide that I showed you, I had a fairly wide epidemiology or prevalence for the primary hyperaldosteronism, anywhere from 1 to 15%. And that's a lot of the studies that have looked at the prevalence have shown fairly wide prevalence of it, and it's not only in the primary setting, in the primary care not only in the specialist setting, in the tertiary care setting, but also in the primary care setting. That's raised concerns for a subclinical primary hyperaldosteronism. And because of the concern with it, aldactone was recently added as a suggestion as second-line therapy in the JNC8 guidelines. And it's subclinical because you often don't get the classic triad of hypertension, hypokalemia, and metabolic alkalosis. And the hypokalemia tends to be one of the main findings that tend to be not consistent. And it's really based on the fact that renal K-wasting requires 2 concomitant factors occurring at the same time. One is a high sodium intake or distal delivery of sodium and elevated of the aldosterone levels, because aldosterone works on the distal convoluted tubule and it needs sodium within the tubular lumen to actually do its activity. And so when there isn't sodium delivery to the distal tubule, either because of mainly because of a low sodium intake, you're not going to get hypokalemia. So diuretic-induced hypokalemia is often a sign of hyperaldosteronism. And so whenever, even if somebody's got resistant high blood pressure and has some potassium requirements, that's generally is very suggestive of hyperaldosteronism. So in terms of diagnosis, serum aldosterone and renin are the mainstay. And renin is secreted by the juxtaglomerular apparatus and sensitive to pressure and sodium. And that should be suppressed in primary hyperaldosteronism because you have independent secretion of aldosterone. The criteria are based on the ratio of aldosterone to renin, which is over and the diagnostic criteria is for it to be over 20. That alone doesn't make the diagnosis though, because the ratio tends to be very denominator dependent. And so if the renin is less than 1, it really can it's very easy to get that ratio greater than 20. And so having an aldo level greater than 25 is also the second component of that. That being said, and I just mentioned that the ratio is very denominator dependent. A renin less than 1, from my standpoint, raises concern for suppressed renin. And in the literature that's been published regarding primary hyperaldosteronism, a low renin is really the most consistent finding rather than a high aldosterone level. And the other thing that I think is very important for everybody to know is that ACE inhibitors and ARBs and diuretics all lead to elevated renin levels. And in a suppressed renin in that setting is very suggestive of primary hyperaldo. A case that I wanted to share with you guys that really kind of opened my eyes to this was a elderly gentleman. I'd been seeing him for a couple of visits, but then he started having problems with heart failure. And he was on Lasix and some potassium, and his EF was actually fairly reasonable. Blood pressure was under good shape, but he kept having these issues with heart failure. Just off the cuff, I ended up checking a renin and aldo, and his renin, I think, was in the 1 range, and his aldo was not terribly high, so I wasn't terribly concerned about it. But then we weren't able to get it under. He kept having these issues with heart failure, and we weren't getting anywhere. So I actually went ahead, and I was worried about doing this salt loading 24-hour test that I'm about to tell you with. So I actually stopped his ACE inhibitor and his diuretic for a couple of days just to try and get a sense of what his renin was like. And so on all those drugs, renin was in the 1.5 range, but after we stopped all that, his renin was undetectable, and his aldosterone level was in the 20 range. And so then we started him aldactone, and all his issues with heart failure went away. So as I'd mentioned, the salt loading 24 hours, so you can see that the renin and aldosterone are often not diagnostic for primary hyperaldo. So the salt loading 24-hour urine is another test that's been utilized to diagnose it. And it's based on the fact that a high sodium intake will suppress normal aldosterone secretion. And so the typical protocol is you have patients eat an extra teaspoon of salt for a couple of days, and then you measure a 24-hour urine. And on the 24-hour urine, you check their sodium and then you check their aldosterone level. If they've been eating a reasonable amount of salt, and on their 24-hour urine, if their urine sodium has hit more than 200 and their aldo level is greater than 12, that kind of clinches the diagnosis of primary hyperaldo. So in terms of treatment of hyperaldo, medical therapy is based on mineralocorticoid agonists. And the other thing important to note is that the dose is titrated to normal kalemia. You don't really titrate the dose to blood pressure control. There's 2 main drugs to use. Aldactone is the older drug. It's fairly long acting. It does have numerous side effects, but it is inexpensive. So that's generally my first line. Inspira or Eplerenone is shorter acting, less side effects. But for some insurances, it can be expensive. So I generally will start with Aldactone and then switch to Inspira if there are limiting side effects. B-pill will improve over weeks, so de-escalate meds slowly. And the other is to expect an increase in the creatinine. Invariably, after I start, and I can't tell you the literature based on this, but in my experience, invariably after you start aldactone, the creatinine is going to go up. But again, similar to our discussions before, the blood pressure control is more important than the creatinine, particularly in non-proteinuric, patients where, as long as their blood pressure is in control and you don't have any other new insults, you won't expect progressive disease. Surgical therapy. So unilateral disease tends to be the minority of patients. And for most patients who are interested in surgery, you're going to need something called adrenal vein sampling. And as it's indicated, it's indicated in all patients who are considering surgery, except if they're young and they have a very large adenoma, or there's a concern for adrenal carcinoma. I mentioned large adenomas greater than 5 centimeters as well, because even if they're dormant, even if they're not hormone secreting, those need to be excised just because given the risk of cancer. But other than that, unless somebody's less than 40 and has a large adenoma, you want to go ahead and do adrenal vein sampling if a patient's interested in surgery and you've confirmed the diagnosis of primary hyperaldo. And you're basically looking at the aldo levels between the 2 adrenal veins to give an indication of whether somebody will respond to therapy or not. And then again, the blood pressure will improve a little bit more quickly with surgery, so you want to kind of scale back the meds fairly quickly with that. One last point regarding this. Historical data does have suggested that patients with primary hyperaldo do have more cardiovascular disease than essential high blood pressures, even independent of blood pressure. So if you have two people with a controlled blood pressure, both of them have controlled blood pressures, but the old literature would suggest the patients with primary hyperaldo would have more risk of cardiovascular disease over their lifetime. However, and that's why adrenalectomy has generally been suggested as a treatment of choice. However, more recent data would suggest that if the renin is unsuppressed, so basically you give them enough aldactone, and that so that the renin starts coming up a little bit in response to that, that their outcomes are similar to the general population. And so there, may be some role more so for medical therapy rather than surgery kind of in the future, given the fact that outcomes do tend to be equivalent if you are able to get the renin up a little bit. And that was it.
Thank you, Sheru. That was fantastic. Really comprehensive overview. Just going to give people a couple seconds just to think about their questions, maybe chat them if you wish. I just had a question for you. From the sort of primary care health services standpoint, we see this a lot. So I've got a patient, I put them on one agent, two agents. They're relatively young. The onset of hypertension is maybe fairly recent, maybe 3 agents. What would you suggest as an initial investigation for secondary hypertension? Should we go for an MRA, just an ultrasound?
Sure. A lot of it depends on age. And so
like 35-year-old.
Yeah, I would probably with the duplex generally. So the female, I tend to be a little bit more aggressive with young females compared to males, just because of the prevalence of FMD in younger females compared to males. So if I have a young female, I'll start with the duplex, but I generally won't stop at the duplex. Okay. I'll go ahead with the CT if it's a young female. But beyond that, if the duplex is negative, I'll stop there.
Oh, okay. And if let's say it's a young woman with fibromuscular dysplasia, you've got renal artery stenosis, based on your presentation, you're suggesting just continue to treat aggressive, obviously maybe refer to nephrology, but you would just treat medically. Yeah. And see what you can do. Yeah,
historically, while ago, I thought that FMD, most patients with FMD are recommended to get revascularized, but I think that's kind of changed a little bit. I think that as long as it's similar to, atherosclerotic disease at this point, if you control the blood pressure, the vascular medicine docs really aren't recommending revascularization on them much anymore either.
That's really helpful. All right, May 17th at Nationwide Hotel and Conference Center in Columbus. La Princess Brewer is going to be our keynote speaker as well. Look forward to seeing you all there. And Shannon, back to you.
Thanks, Dr. Rao and Dr. Kansal and Dr. Wright as well. We did want to remind you that there are CME credits available for this session. And after the series is over, we will be sending a survey to complete for your CME credits. Today, a survey is mailed to you to complete for the post-clinic survey. And you have until 5 o'clock tomorrow to complete that. So next week, we will have a presentation from Dr. Dean Bricker from Wright State University on shared decision-making and hypertension management. So please join us and we'll see you then.
Okay,
thanks everyone.
Thanks everyone.
Thank you.